Hello and welcome back to Athro Talk, the podcast brought to you by the EAS Young Fellows. I'm Azin Kheirkhah from the Institute of Genetic Epidemiology in Innsbruck, Austria. This episode is a special one dedicated to Familial Hypercholesterolaemia Awareness Week, a time to raise global attention about this common yet underdiagnosed condition. To mark this important occasion, I'm thrilled to be joined by Professor Steve Humphries, a leading authority in cardiovascular genetics and FH. Thank you, Professor Humphries, for accepting our invitation.
You're very welcome. I'm extremely happy to be here and to be able to share with you some of my thoughts and research about FH.
Thank you very much. So before diving into my burning questions on FH, I would love for you to introduce yourself to our listeners.
So I was born in London. I did my first degree at the University of Sussex in Brighton. And then I moved to do a PhD in Glasgow, actually in a cancer research institute. But at the time, we were not particularly interested in cancer. We were interested in the control of gene expression, which obviously is important in cancer. And the model system we were studying were the globin genes, the expression of the globin genes in mice, with the hope that we could then move on to looking at the globin genes in humans, because obviously we're very interested in the genetic disease called thalassemia or sickle cell anemia. And after working there, I moved to Salt Lake City in Utah and worked there for 3.5 years. And my first son was born there. We then came back to England, and I then worked at, first of all, St Mary's Hospital in London for 6 years, and then Charing Cross Hospital for 6 years. And it was during this time that I started working on the genetics of heart disease. I then moved to University College London in 1991, and I've been there ever since. I actually retired 10 years ago, but I'm an emeritus professor at UCL, and I'm still working on FH and trying now more or less to get the implementation of all the findings to ensure that there is patient benefit.
Thank you very much. And is there something about you that most people in the academic world don't know about, like perhaps a hobby or a passion, a personal passion that you have?
Well, some people do already know this. I'm a very keen singer, both of folk music and of choral music and sacred music. I used to go every year to the European Lipoprotein Club, and I'd recommend any young fellow who is interested in the field to go there. It meets in a town just outside Munich every year in September. It's really an excellent meeting, especially for networking and for science. And what we started is a tradition in the after the banquet of doing some singing, folk singing from different countries, and singing Beatles songs and ABBA and everything else. So I sing in a choir. I've always sung, both in church choirs and in others. I'm a tenor, and we've actually got our next concert on July the 5th. So I'm busy practicing all sorts of different songs.
That is actually very impressive. And I was also at the ELC meeting last year, and I'm really sad that you were not there last year, that I could actually hear the songs. So perfect. So can you briefly tell us about your academic journey, as in how did you really, like, were there mentors that helped you to actually find your niche into the FH research?
Yes, my PhD supervisor, whose name is Bob Williamson, is a very charismatic man with a very clear vision about how we should be able to use genetic information to find individuals who are at risk of genetic disease, and how to empower them to improve their health. And I very much took that on board. It chimed very much with what I feel as well. And so I've always had a two-pronged aspect to the research I do. One is finding the cause the particular health problem that an individual has, and then explaining to them what they can do with this knowledge to improve their health. So it's about empowering people. It really is. As you know, the old, if you like, the old medical model is patient sees doctor, doctor says you must do this, this, and this. Patient goes away and either does it or doesn't do it. Well, that's no longer seen as the most useful way to help and support people to do what they have to do. It's about giving them information about their disease and how to improve their health, and to empower them to be able to improve. And so it's not the top-down, doctor, you must do this. It's patient says, well, what sort of things can I do? And you say, well, you could do this or you could do that, and that'll do this and that. And the parent, oh, right, I'll start to do that. So that I've always seen as the best way forward. So not only have I been doing, if you like, applied research, but I've also been doing what we would call implementation research, about taking it out into the community. The problem with that is you need funding for the implementation, and that's much harder to get than funding for the research. So I must say, although we now know a huge amount about the genetic causes of FH, and of course because of the now huge number of different lipid-lowering therapies we can treat people with FH very well. It's just finding them that's the problem, and then getting the implementation of that. So that's really the part that I think we still got a lot of work to do.
Yeah, and you're absolutely right. Implementation is actually very important. So a question for actually our early career listeners. They might be curious to hear your answer. So what motivated you in the early career stages, and like when you were going through tough times, what kind of advice do you have for early career scientists or clinicians?
Thank you. That's a very interesting question. The key thing about having a successful research career is finding a research question where you can get a grant. It's no good having the best, cleverest idea in the world if no one is going to fund it. And the good thing about heart disease and familial hypercholesterolaemia is that there is a lot of interest in funding research in this, because of the obvious benefit in finding people before they've had a heart attack and being able to lower their risk. And so I was very... So I won't say I was lucky, because it was a good choice that the British Heart Foundation has as its one major remit research into preventing cardiovascular disease. And one of the first things that we were able to do when I was at St Mary's Hospital is ask people from the British Heart Foundation, the BHF, to come and visit us and see us working in the lab, and explaining to them what we could do. And they said, this is a very good idea. They'd not thought of this aspect, I think, up to that time. And I said, please put in a grant. And since then, I was able to have British Heart Foundation funding and I was a BHF professor for more than 30 years. And when I retired 10 years ago, the head of the BHF estimated that over that period, the BHF had given me more than £15 million of funding. Now, of course, that wasn't all coming to me. It was to support the postdocs and the PhD students and the research assistants and on all the reagents. But it was very much a mark of their support for this whole piece of work. So that's really the first thing you've got to do. To succeed, you have to have a question that is fundable. And I think the other thing to remember is that just because a grant doesn't get funded the first time, it doesn't mean it's not a good idea. It just means you haven't explained it well. And just as when you submit a paper and it gets rejected, you have to look at all the comments, and often you look at the comments and the referee says, oh, you've forgotten to do this. And you say, no, I did this. That was on page 17. They obviously haven't read it. Oh, blood boils, blood pressure goes up. But that is just the job. You have to go back and explain it in a better way, in a way that they can understand. And what you have to remember to do when you're talking to patients, to clinicians, and to grant funding agencies and to journals is, if they don't understand it, you have not succeeded. And don't be upset and angry if you can be upset, but don't be angry if they didn't understand it. You've just got to find better ways of explaining it to them. So that, I think, is a very important lesson.
Thank you. So communication and the presentation skills are very key.
Exactly right.
Yeah. And looking back over your career, is there a particular discovery or moment you're especially proud of?
The exciting thing about research, as I'm sure you've found and many of our listeners will have, is, if you like, that eureka moment when you develop a photograph, or you run a gel, or you find something, and you look at this and you think, my goodness, no one else in the world knows this. We have, for the first time, discovered a variant in the LDL receptor gene that no one else knew about. We have found a way to change something that is going to happen. And there's certainly been moments like that in the whole procedure. But mostly it's incremental. I mean, those eureka moments are wonderful, but mostly it's, okay, we've got this 10% better. We've now got it 20% better. We've now got it 30% better. And when you look, each of them, you think, oh, that's okay. When you look back and you realize you've now doubled your ability to find mutations in the LDL receptor, it builds up slowly over time.
So now we can dive into all the FH questions that we've got. So let's start with a quick clinical recap. So our listeners know the basics, but for context, how would you currently define the scope of FH in terms of public health?
The important thing about FH, which we've realized just in the last maybe 5 years or so, is how amazingly common it is. It's easy to say it is the most common genetic disease that we know of that is identifiable and treatable, but it is astonishingly common. We now know that the carrier frequency for an FH-causing variant in almost all populations in the world is about 1 in 280, maybe 1 in 300. So it's much more common than we thought. And just focusing on the UK, that means that there are about 200, maybe 220,000 people, just based on the fact that there's 60 million and dividing that by 280, who've got FH, and half of them are men, and half of the men will have developed heart disease by the age of 50, unless we can find them and give them lipid-lowering therapy. Obviously, half are women. About a third of women will have developed heart disease by the age of 60. So women have the usual the gender protection of high HDL till they reach the menopause. And so there's just an awful lot of people out there who, and most of them are not aware that they have this high risk because they've never had a cholesterol measurement. And if we can find them, we can lower their risk to that of the general population. In the UK, we have this Simon Broom registry of people with FH. It was Simon Broom was a man who died of an early heart attack, and his widow Kathleen set up this register as a charity back in the 1980s, with the aims of finding the causes of FH and the early death, and working out how to lower risk. And the register has allowed us to follow up patients with FH, because every time there's a death, we get the death certificate and we can see if they've died of heart disease or stroke or cancer or other sorts of things. And what we showed is that before statins were available, the death rate was maybe 5 times higher in FH patients than the general population. When statins became available, that dropped quite a lot. And when the high-intensity statins that are now available, that's dropped to the point where the death rate from heart disease in treated FH patients is the same as in the general population. So obviously, lipid-lowering therapy works. Interestingly, what we noticed, and that we were very surprised at, is that the death rate from cancers in treated FH patients was actually lower than the general population. Now, this could be due to some magic effect of statins. When we looked at the data, the cancers that FH patients are not dying from are smoking related. So they're not dying of lung cancer or bladder cancer and things like that. And what we believe is happening is that the FH patients are told by their clinicians, healthy lifestyle, healthy diet, do not smoke. And the smoking rate in the FH patients on the register is considerably lower than in the general population. So if you like, having FH and being identified gives you the extra benefit that you quit smoking and you don't get these cancers. So all in all, being able to identify people with FH early and give them the advice and treatment that they need is extremely beneficial. The problem is finding them.
Exactly. And when you say FH, do you mean it as a phenotype, people fulfilling clinical criteria for FH, or only people genetically diagnosed for FH? And in which context do you think this difference really matters?
Very interesting question. So when we go to any of our lipid clinics that we work with and say, give us 100 patients with clinical FH, about a third of them have what we would call definite FH. So they've got a really poor family history. Maybe they've got tendinxanthomas, although that's less and less common these days. And about 2/3 of them would have a clinical diagnosis of possible FH. And the mutation detection rate in the definite FH patients is quite good, maybe 50, 60%. In the possible FH patients, it's much lower, maybe 20 or 30%. But because the possible FH patients are twice as common as definite, in the 100 patients overall, we can maybe find a mutation in maybe 40% of them or something like that, maybe slightly less than that. So in the in the patients that have now got a mutation, they clearly have FH. And we know that from many studies that they are at particularly high risk and that they need to be managed in lipid clinics in order to have the combination of lipid-lowering therapies that we now know is useful, using statins and ezetimibe and maybe PCSK9 agents and all the rest of it. The individuals where they have a clinical diagnosis but not a monogenic cause are very clearly at a lower cardiovascular risk. We've shown this, many other studies have. But they still have an elevated risk compared to the general population. And what we found in a landmark paper that we published in Lancet in 2013 was that in a large proportion of the no mutation but clinical FH patients, the cause is actually what we would call a polygenic cause. What these individuals have is, if you like, by bad luck, they've inherited a greater than average number of common genetic variants spread throughout the genome that by adding up, means that these individuals have a genetic cause for their high cholesterol, but because it's not monogenic, it is not associated with as high a risk as if it were monogenic. And what these individuals need is clearly lipid-lowering treatment, but it doesn't have to be as intensive management as for the monogenic cause. And these individuals can actually be managed, we think, quite well in general practice. So this is, if you like, a very good example of how we can use genetics to risk stratify. So we take all these people with clinical diagnosis of FH, we can find a monogenic cause in one group, they're high risk. We find a polygenic cause in others, and they are at lower risk. And then these individuals can be managed in quite a different way. This is both cost effective, but it also means that people are treated in an appropriate way.
Thank you. And since we're speaking of the genetics, can you briefly mention the FH genetic variants and like how many of them are currently identified, and what do you think are the best methodologies to screen for FH?
Well, I've been very privileged to work with a number of people in the field who are all as passionate as I am about working out what the genetic causes are of FH. Thinking particularly here of Mafalda Bourbon, who's in Portugal, and her colleague Joana Chora, Thomas Freiberg in the Czech Republic, Derek Rahl, who's in South Africa, and then colleagues in America as well. And altogether, we've all been working on looking at the genetic causes that have been reported in patients with FH and working out which of these variants are actually pathogenic or likely pathogenic, which of the variants that have been found in the different genes are likely benign, and we're still left with a group in the middle where we call them variants of uncertain significance, or VUS. And in the world literature, there's more than 2,300 different variants in the LDL receptor gene, and most of them are likely pathogenic or pathogenic, but some are not. In the ApoB gene, there are a large number of variants, most of which are variants of uncertain significance or are benign or likely benign. There are two common variants in the ApoB gene that both alter the amino acid at position 3527 of the whole very long ApoB protein. They change an arginine to a glutamine, and that's the common mutation in people of European origin, or an arginine to a tryptophan, and that's the common mutation in people from the Indian subcontinent. And both of those variants cause the LDL to bind poorly to the LDL receptor, so the LDL is not cleared and levels rise in the blood. The third gene where mutations cause the FH phenotype is the gene called PCSK9, and gain of function variants in PCSK9 mean that the protein binds more avidly to the LDL receptor ApoB complex on the surface of the liver, and instead of being able to, the LDL receptor being able to recycle to the surface and do its job again, the LDL receptor ApoB PCSK9 complex is targeted to the lysosome where it's degraded. So gain of function PCSK9 again means less LDL receptors on the surface of the blood to function. And then just recently, it's been shown by a French group and confirmed by several others that a 3-base pair, a deletion in the gene for ApoB, which deletes one amino acid, the leucine at position 167, can also mimic the FH phenotype. So we know of these 4 genes where having a pathogenic variant causes the FH phenotype. The best way for doing genetic screening in the diagnostic laboratory is to use next generation sequencing of all the genes, all the exons in the genes, the intron exon boundaries, and some of the 5' and 3' untranslated regions. The 5' region is the area which is in key in making sure the transcription of the genes is important. And there are a number of functional variants in the promoter region of the LDL receptor that are very clearly important to know about. For the LDLR particularly, about 5, maybe 10% of the causes of FH are due to large rearrangements of the gene, either deletions or insertions. And I can explain the mechanism about how that works if you're interested. But it is very clear that in order to have a comprehensive screening, you need to have a methodology that allows you to pick up whether large parts of the gene are duplicated or are absent. So next generation sequencing works very well, and that is if you like, the gold standard. Many laboratories, as well as covering the 4 genes that I've mentioned, add several other genes that are involved in determining the less common recessive causes of the FH phenotype, such as the ABC, G5 and G8, lipid transporters, and the LDL receptor associated protein 1, which causes recessive hypercholesterolaemia, most commonly found in patients from Sardinia.
Thank you very much. You have championed the cascade screening and the genetic testing for FH and helped to set up the first FH diagnostic service in the world more than 20 years ago. Could you walk us through how that's structured in the UK and what has worked?
Yes, well, as a genetic disease, which you often call is an autosomal dominant a disease, then what this means is that if I have FH, I've got one normal allele, let's say the LDL receptor, and one allele that doesn't work. I inherited that from one of my parents. My father had an early heart attack, so it was probably him. And I've got 4 children. So on average, I will have given the defective allele to 2 out of my 4 children. I've also got a brother and a sister. On average, one of those of my brothers or sisters will also have inherited the defective allele from my father. So by finding me, I've probably on average got 4 or 5 living first-degree relatives, and therefore on average at least 2 of them probably are going to have inherited the defective allele. So by finding me and testing the first-degree relatives, then you can identify at least another 2, maybe 3 more individuals. And we call this cascade testing. Obviously, you don't have to stop at first-degree relatives. My brother didn't have the mutation, so don't bother testing his children. My sister had the mutation, so test her children. She's got 3 children. Oh, look, and 1 or 2 of them have got that as well. You can also test my cousins, and then you can spread it out. So this approach works extremely well in countries where there are large families and in countries where people tend to live close to each other and they don't move around a lot. So this approach has worked extremely well in Holland. Holland is, as you know, a very flat country. It's not very big, and people tend to like their families and keep in touch with them. And so the approach there has been to use what they call genetic field workers. They give them a bicycle and a computer in a backpack, and they cycle around and go and visit people in their home and say, right, you have FH, as you know, your doctor's found this. Please, can you tell us about your relatives? And is it okay if we contact them? And then people also always say yes. So they then get on their bicycle and cycle to the next village and visit the next people and take a blood sample, and so it goes on. So it works less well for example, in London, because many people in London have moved there from somewhere else. Many people in London come from different countries, and so they may have come from the Indian subcontinent, but all their family is back in India or somewhere else, and it's much harder to contact them. So in metropolitan areas, the number of relatives you can test is often much less than we would like, and much less than the modelling suggests. So it's not that it's not a good idea, it's just we have to be much more clever in doing it. And although it would be ideal to do cascade testing using both a cholesterol measurement and getting a blood sample for DNA, you don't need to know the cholesterol, you just need to know whether they've inherited the bad gene or not. So the way we would like to be doing this is to be sending people through the post once you've contacted them and say, would you like to be tested? Send them just through a sample for doing a mouth swab. So they can do that at home. They just rub around their mouth with a little brush, put the brush into the tube, put the lid on, and post it back to you. So you can then test whether they've inherited the family mutation or not. It's a very quick, cheap test. And then if they don't have inherited the mutation, you can reassure them and say it's okay. If they have the mutation, you can say, you should get a blood lipid test. Please go to your GP. Here's the letter to take to your GP, and the GP can then tell us the results. And then, so even if they're living miles away or even in a different country, this approach would work very well. So this is the sort of thing we would like to do. However, what it needs is, we would call them an FH nurse, but call them an FH genetic field worker is more appropriate. And getting funding for these has proven very difficult. I was able to persuade the British Heart Foundation that funding these FH nurses would be a good idea. And about 10 years ago now, they put in about £1.5 million to funding 29 FH nurses throughout the country, covering about half of the UK. And surprise, surprise, where there were FH nurses, lots and lots of cascade testing was done, and lots of children and people with FH were found. In the half of the country where there were no FH nurses, there was no cascade testing done, and no one was found. And the sad thing was that the BHF funded this for 3 years on the assumption that this service would be shown to be so valuable that the trust, the health trust, the hospitals would then take on funding, and they haven't. So most of those posts have now ended, and it is currently the state of cascade testing in the UK is that there is very little being done. And that's not because people don't want to do it. It's not because the lipid clinics are not interested in doing it. They are. They just don't have time within the busy schedule to be able to do it. So what cascade testing needs is someone whose job it is to do it, and then it gets done.
Yeah, absolutely right. And we have come across an article published by the British Heart Foundation in 2023, where you mentioned that you were going to retire when 25% of FH patients were identified. And how close is this target right now?
Yeah, so I'll tell you a little story about that. The NHS published what they called was a long-term plan for health of the UK in 2019, and it had a number of different aims. It was clearly involved in identifying early people with cancer and treating them, people with diabetes and obesity, people with dementia, and people at risk of heart disease. So those were if you like, the four big ones. And whilst they were preparing this, I was in the Department of Health by chance, and someone came up to me and said, so we're thinking of putting in an aim for finding patients with FH over the next 5 years. We think we should be able to find half of the 200,000 patients with FH. Do you think that's reasonable? I said, no. As much as I would like to say yes, you'll never do it. If we can find 25% of the patients within the next 5 years, then that would be terrific. So I said, oh, good. So they wrote that down. So the long-term plan published in 2019 says 25%. Now, at the time, we knew about 7, maybe 10% at most of the predicted number. And I'm really sad to be able to say that now, 5 years later from the publication of that, it's probably gone up to maybe 12%, but it really hasn't shifted much at all. Part of the problem, of course, was we had a pandemic, which meant that there was very little done on any of these fronts, except in dealing with the pandemic, of course. And FH at the moment has really fallen off the agenda in the UK. And it's not because I haven't been trying to put it on the agenda. It's not because the Heart Foundation and the other cholesterol charity in the UK called Heart UK haven't been trying to keep FH on the agenda. It's just because there are so many other major health problems. As you're, I'm sure, all aware, we in the UK or worldwide are struggling with the epidemic of obesity. And the obesity epidemic is pushing the epidemic of diabetes. And so the patients with diabetes obviously have all sorts of other health problems, heart disease, but eye disease, kidney disease. And as the population gets older, we're having more and more cases of dementia. And so these are the big ones that the NHS, and cancer, of course, these are the big ones that the NHS is trying to grapple with. And heart disease has sort of fallen off the bottom of the list. It's very easy for the NHS to say, oh, heart disease is sorted. We've got all these lovely drugs. We just give them the drugs. We don't have to worry about anything else, which is to some extent true, but it overlooks the high risk that people with FH have. And so I still believe that the NHS should be putting more effort into identifying people with FH early, but at the moment it's not high enough on their priority list.
And we briefly touched on the topic of genetic variants, and are they currently reflected in the treatment choice? How far is this concept from personalized medicine in FH?
Well, yes, it's a very good question. The treatment goals are to lower LDL cholesterol to 1.8 if you don't have heart disease, 1.4 if you do. And as you are all aware, the treatment goals for LDL lowering are moving lower and lower, as firstly we realise that low is still safe, that there's no concern about other issues. And we now have more and more agents that will allow LDL to get down there. So people with FH clearly have elevated levels of LDL cholesterol. And back in the old days, we would say, so if you look at the NICE guidelines that I was part of the guideline development, we published in 2008, we said people with FH should aim for a 50% lowering of LDL. Well, that's fine if your LDL is 4 and you get it down to 2. If your LDL is 8 and you get it down to 4, that's no use at all. I mean, you've had some benefit, clearly, but you're nowhere near target. And so we have changed the targets for FH. Instead of this percentage lowering down to specific lowering, now we have the agents that can do that. So if what we know is that some variants that in the LDL receptor, or particularly the ApoB variant, are relatively mild. So that someone with a particular LDL variant might have an LDL of 4, and someone else with another variant might have an LDL of 8. But what we're not, or someone with the ApoB variant might have an LDL, let's say, of 5. But what we're not saying is they've all got to have a 50% lowering. What we're saying is they should all get down to target. And so someone who has the ApoB mutation, because they start with a lower level of LDL, and because they have 2 functional LDL receptors, will usually respond very well to a statin and might not need 3 or 4 different lipid-lowering agents, but might be able to achieve that target of an LDL of 2 simply by a high dose of an intensive lipid-lowering statin like atorvastatin, for example. So it's not so much as saying, OK, you've got this variant, I will give you this drug. It's more saying, your LDL is this, and I will get you down to this target, whatever the LDL is. So that's part of the argument. So in a way, it doesn't matter what your genetic cause is of your high LDL. It's what it is and how low we've got to get it. As I mentioned earlier in the talk, the people who've got a polygenic cause of their hypercholesterolaemia, they still very clearly will need LDL lowering. And again, in general, they can get down to the target level without having several different lipid-lowering agents and with intensive statin. But if they need it, then that's what they should get. So it doesn't really depend quite so much on exactly what your genetic cause is. It is simply let's treat the LDL. The advantage of having a genetic cause to you as a patient is knowing what it is that's caused your high cholesterol, because you can understand it then. What we believe is, and there is some evidence from studies, that knowing that you have a genetic cause of your high cholesterol motivates you to take the medication. You certainly remember it better, you can explain it better, and clearly knowing the genetic cause allows you to do the cascade testing. So the major advantage to an FH patient of knowing that they've got a monogenic cause is I can test get my relatives tested if they want, and I'm definitely going to take my drugs, because without the drugs, I won't be able to get down to that level. So there is some clear advantage to the patient of knowing this.
Thanks a lot. So before we wrap up this episode, so one last question. The cascade screening approach was implemented across the world and gave rise to FH registries. One of them, the Global FH Registry, which was established by the EAS Familial Hypercholesterolaemia Studies collaboration. How did this influence the FH awareness among clinical practitioners and patients? And which programs or initiatives are currently most successful?
Well, the FHSC, which was started by Chora, he's now the past president of the EAS, has really been an astonishingly successful program. I'm not sure he realised what a challenge it was going to be when he started it. I've been a part of the group, and it's been a great privilege and an awful lot of fun to be able to work with so many people from so many different countries. The major findings, as I'm sure you're aware, are in a sense not a surprise. What we have always suspected is that people with FH are found at a late age. We want to find them when they're in their childhood, 10, 15, that's when we want to start. The mean age of finding them globally is about 55, 57, way too late. We know many of them have already had a heart attack, way too late. What we know is that, from recent studies, is that if you're overweight, if you're diabetic, if you have high levels of Lp(a), you have much higher risk of developing heart disease if you're an FH patient than if you don't. In a way, this isn't a surprise, but getting it documented means that we can go to the healthcare systems in the different countries and say, look, this is the data, this is what's going on, we need to work together. And so having this documented in such a large sample, representative of the whole world population, is extremely valuable. We need the data, we've got to have solid data, and that's what this is provided. We are working now, I'm part of the genetics group, we're working on the genetics of the findings in all these patients. And I have to tell you, it has been a real challenge. And what it's shown us very clearly is that although there is genetic testing being done in many different countries, that there is not a clear standard and guidance about how to do the screening, how to interpret the data, and how to make sure that the data is recorded and then the clinicians and the patients informed. And this is one of the big lessons that we will be able to get out to the community, that FH testing, which is important for all the reasons we've talked about, needs to be done in a standardized way. And at the moment, it isn't standardized enough. And a number of the patients who are on the register, who the clinical leads in the different countries say, this person has got monogenic cause of FH. We look at what the information says in the register, and he says, no, we know this is a variant of uncertain significance. We're not sure this person has FH or not. And clearly there needs to be, as I said, just better guidelines, better ways of standardizing this data. So again, this is a lesson which I think this global registry has allowed us to address. And I hopefully within the next year or so, this paper will get published and we can move this whole thing forward.
Thank you very much, Professor Humphries. It was really an insightful conversation. We truly appreciate your time and insights.
It's been a pleasure. Thank you very much.
Thanks a lot. And for our listeners, if you're involved in lipid clinics, primary care networks, or cardiovascular policy, let this be a reminder. FH is common, serious, and treatable, but only if we find it. Thanks for listening, and until next time.